So we'll get started now. Hello, thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started today, I'd like to cover a few expectations. Today's seminar is being recorded, and the public slide deck will also be made available on our website under the Education tab. And I will also post the link to that page in the chat. Following the presentation, we invite you to raise your hand if you'd like to ask a question verbally, or you can type questions into the Q&A section of the Zoom webinar. In particular, we welcome questions exploring the many dimensions of impact that these ideas and practices have on learning health systems. So as a final reminder, we are taking a pause from the seminar during the end of the year holiday hiatus that we all take. So our next impact seminar will take place on Tuesday, February 7th with Dr. Rachel Richardson from the University of Michigan and their Department of Learning Health Sciences. And with that, I will turn it over to Dr. Tim Beebe to introduce our speaker.
Thanks, Lindsay. Thank you all for joining us today. It's exciting to introduce Dr. Rohit Ramaswamy, who serves as Professor of Pediatrics, Co-Director of Research at the James A. M. Anderson Center for Health Systems Excellence at the Cincinnati Children's. So prior to joining Cincinnati Children's, he was an Associate Director of the Public Health Leadership Program and a Professor in Maternal and Child Health at the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. Dr. Ramaswamy has a Bachelor of Technology degree in Mechanical Engineering from the Indian Institute of Technology, MS and PhDs in Civil Engineering from MIT, an MPH degree from the University of North Carolina at Chapel Hill, and a graduate diploma in biostatistics from the University of Sydney. So he's definitely well educated. Dr. Ramaswamy's area of expertise is in implementation and improvement science, topics and disciplines of near and dear to our hearts. They deal with the development and evaluation of systematic methods and tools to sustainably implement and improve complex interventions. His work blends the tools of system science, design thinking, implementation science, and CQI to build capacity for implementation. With a deep interest in global health, he has worked on improvement of clinical and operational processes in tertiary maternity hospitals in Ghana and integrating mental health service delivery in the district primary healthcare systems in India. He's also developed and taught implementation science programs in South Africa and in Zambia. So his talk today is Learning Through Spread, Evaluating Community Health Improvement Initiatives in 20 communities in the US. I'm excited now to hand it over to the star of our show, Dr. Rohit Ramaswamy.
Thank you, Dr. Beebe. Thank you for the introduction, and it's a great pleasure to be here. Let me bring my slide up and make sure that everybody can see my slides. Can people see the slides?
Yes.
Okay, wonderful. The work that I'm going to talk about, so as Dr. Beebe said, I have just joined Cincinnati Children's about a year or so ago. So a lot of this work is work that I did when I was at UNC Chapel Hill. By way of preamble, a lot of this talk is going to be more about questions than about answers. As Dr. Beebe said, as we think about learning health systems or learning community systems, we are constantly confronted with the fact that a lot of our research work happens in the field, happens where either we provide patient care or in community public health settings. And so our research challenges are how to actually be able to think about getting rigorous insights and participatory ways from real life settings. And this is what I'm going to talk about is a project that I was the evaluation co-lead on for 4 or 5 years. And this was a community improvement capacity building project. And it came with a large amount of complexity on the ground. And the topic of my talk today is what we learned, what we did not learn, what we could do, what we could not do, more as a way of continuing to advance the conversation on how do we really learn from what's going on in the ground. I'm hoping to talk for about 40 minutes or so, and then I'll open it up for questions. There's a lot of, as I said, because there are no answers, it would be great to have a discussion around, your experience, questions you have, and so on. So let me get started. The general impetus for this kind of work is to think about systems transformation in complex systems. And I am presenting this slide not because this is the work that we did, but to give a sense of the way in which kind of the challenges of today manifest themselves in communities. And so these are a selection of headlines that come from our recent and ongoing COVID crisis. And as you can see, the headlines are not just about the fact that people are contracting COVID, landing up in hospitals and dying of the disease, but it has ripple effects in a lot of other sectors. So the deaths of despair, there's racism, there's mental health issues, there's jobs, there's unemployment, economic issues. The question is, how do we, any work that we do in the community settings, therefore cannot think about community improvement in general, has to address the fact that anything that we do, when we think about community health, or even when we think about patient care, has to be in the general context of the world in which the patients live, work, and play, or the community members live, work, and play. And therefore, we cannot really think about doing embedded work in communities or with patients without kind of paying attention to all of this other complexity that is going on. And so over the last couple of years, there has been this movement towards thinking more about complex systems, doing health systems research within the framework of complex systems, rather than thinking about kind of individual reductionist projects. And Hillary Cottam is a well-known designer who's done a lot of really, really interesting work about, thinking about redesigning social systems. So really kind of thinking not about how we have traditionally addressed issues in the past as siloed, kind of one at a time approaches where we have a problem and we're fixing the problem, where if we have a need, we do a needs assessment and try and think about how do we manage the need. What a lot of the work is kind of closed and targeted, to how do we begin to think about expanding this to a, what she calls radical health, from a welfare system, which really kind of focuses on a deficit lens, to a radical health system that actually focuses on a positive, on a strengths lens. And so think about, being able to transform systems from fixing problems to really kind of enabling them for growth. And so if we begin to think about this kind of context, then we have to, because we're moving from a problem-fixing solution from a problem-fixing approach to a kind of building capability, building an approach of kind of now holistic approach towards kind of better health and better well-being, we have to be able to take complexity into account. There's also been a lot of work over the last few years, particularly led by Trisha Greenhalgh from the UK, around kind of how do we begin to think about incorporating complexity in health services research. And this paper and others that Dr. Greenhalgh has written has been about, again, moving away from reductionist approaches, one at a time research studies, to really thinking about a broader way of addressing some of the issues that faces as we kind of confront large complex problems like COVID or climate change or NCDs and a variety of other issues. So as Dr. Greenhalgh says, part of therefore, if we wanted to think about complexity-informed research, what are the kinds of things we need to be thinking about? It needs to be about generating insights rather than establishing the truth. So there's not really kind of a single truth, but there are many things that we know about the system that allow us to learn about the system. And so for those of us who are working in learning health systems, some of these are kind of aligned ideas. I mean, they make sense to us as we think about not so much about solving a problem, but about learning as we go, right? So it's about plurality of voices instead of single authoritative voice. So this would be, perhaps like things like co-designing with patients, co-creating with communities, but also really thinking about, where does power sit and how do we, reorganize traditional hierarchical power structures, and how do we use principles of where we can take advantage of lived experience in the communities to be able to think about what might be the best solutions as we work with them. And so again, thinking about not so much about effect size, but on, and therefore not really kind of not having a single-minded focus on causality, but thinking more on contribution and how do multiple kind of interventions, how do contextual factors, how do a variety of different embedded good practices together work to contribute to outcomes in communities. And so while all of this sounds great in theory, and all of these are really important, the question is, how do we begin to make these work in practice? What is the balance between the traditional types of research that we do that focuses on trying to think about bringing the best possible rigorous methodologies to try and identify causal influences on a particular outcome, to this kind of broader based approach that asks us to take a look at a lot of different factors and how they interact together in complex ways, so that we can come up with a complex tapestry, a kind of a story, so to speak, of what is going on in the system, but may not allow us to be able to make definitive relationships between cause and effect. We've been continuing to work in this area for the last 5 or 6 years. And in my recent work, as I have begun to take on some work at Cincinnati Children's, we've been working to expand the work that we're doing in the learning health systems area into what we're calling learning community systems. So taking some of these same ideas that we have from learning health systems around the data, the science, the capability, the culture, the incentives, and trying to think about how we might want to use them in order for us to be able to develop this kind of learning capability within communities. And this paper that got recently published is a hypothetical paper. We used data from COVID-19 from North Carolina to show how there were significant differences between the state pattern of the progression of the disease and county level patterns of the progression of the disease, and how therefore really, if we wanted to kind of think about coming up with solutions that worked, where we were not simply mandating that everything shut down for periods of time, but we were actually taking nuanced decisions that took into account what was going on in local communities. We need to be able to build the ability for communities to learn. And we are very far away from that. But this paper begins to talk about some of the capacities that need to be built in communities for that to happen. And some of the learning from this came from the project that I'm going to be talking about for the rest of my talk today. So the project that I'm going to describe is called the SCALE Initiative. And this is an initiative that was funded by the Robert Wood Johnson as part of their Culture of Health program. The Institute for Healthcare Improvement in Boston, that many of you might know about, is a leading quality improvement organization that's known both locally and globally for its QI expertise. Led this work along with several community implementing partners. And the whole idea around the SCALE initiative was to build a learning and doing collaborative within a network of communities. And the idea was to be able to build system capacity, cross-community capacity for transformation. And so the idea of the project was to be able to build the capacity to learn, for each community to learn what worked within their community, and then to be able to create, through this networked system, to create a learning network where there was kind of rapid communities about the things that worked and the things that didn't work, but also begin to create a culture of change and improvement and transformation that then could be spread to other communities within the regions in which the selected communities were based. And when I say communities, each of these were the total number of communities were 20 community coalitions. Each of these coalitions were different. So they were selected through a competitive process. So they had they were scattered all across the United States. They had different partnerships. So some of them were partnered with health systems, some of them had local community organizations, some of them had school districts. And so in each of these communities decided on a particular transformational outcome or a particular transformational objective that they wanted to work on. So not only were there was a lot of heterogeneity across the different community coalitions, but there was a lot of heterogeneity in the kinds of things that they were working on as well. So this entire idea about scale was not necessarily to say, it's not like a learning collaborative where we have a group of people focusing on a common outcome and then coming together in learning sessions to learn about how to improve that outcome. This was 20 different community coalitions working on 20 different things, but coming together to talk about a common process of learning and to think about, how can we share what we're learning? How can we share the capacities that we've built so that we can build kind of an infrastructure and culture for learning and transformation? So that was the idea. And we, the University of North Carolina and the University of South Carolina, we were the evaluation leads on this project. And so what I'm actually going to talk about is our evaluation journey, what we set out to do, what we did, as I said earlier, and what we didn't do. So the theory of change for the SCALE initiative was to essentially build a set of skills in each of these community coalitions that was called the Community of Solution skills. And these skills were a variety. They involved a set of action-oriented training programs, along with a strong support system that provided coaching and mentoring for individual communities and across teams between these learning sessions. And so there were essentially 5 skill areas that these training sessions, which were called CHILAs, they called Community Health Improvement Learning Academies. So these were 3 to 4 days face-to-face sessions, intense face-to-face sessions where the teams would come together to be trained by IHI staff and by a variety of experts in systems thinking, in design thinking, in implementation science, in leadership, from a variety of other areas as well. And so there were 5 training areas: leading from within, leading together, leading for outcomes, leading for equity, and leading for sustainability. And so leading from within was primarily about individual leadership skills. How do we grow my skills to be a leader within my community? Leading together had to do with sharing, collaboration, teamwork, learning from each other, building relationships, for building coalitions for change, and so on. Leading from outcomes was traditionally more of the improvement implementation science areas, using data, developing data systems, using measurement to come up to understand progress, using run charts and statistical process control charts, and some of the kinds of things that IHI does very well. And then equity and sustainability had to do with looking at inclusion, looking at diversity, looking at who was part of the teams, and how do we then begin to use the results of what each of these communities are achieving to think about further growth and further sustainment. And the idea was that by developing these skills and by this kind of coaching system, by putting this coaching system in place, what it would do is it would change behaviors, processes, and systems within these community coalitions and across these community coalitions. So it would change, even if over a 3 or 4 year period, the transformation didn't take place entirely, to the extent that was needed. What it would do is it would build continued strength in how people related to themselves, how they related to one another, how they related to equity, how they addressed equity, how it approached the process of change and transformation. And that in return would build, because this was a Robert Wood Johnson funded project, it would lead to the appropriate culture of health outcomes around learning how to have cross-sector partnerships within your communities, learning how to build coalitions across communities, how to begin to think about improving health as a shared value that multiple stakeholders had. So a lot of the idea was about kind of building infrastructure, building capacity for communities to begin the transformation journey. And so these were the 5 capability building components that I talked about earlier. And the activities, the actual interventions themselves were these community health improvement and leadership academies, the CHILAs that I talked about. And then there were monthly skill building webinars that were facilitated and mentored by a variety of coaches around the country. There were community conversations, there were peer-to-peer group learning, there's expert coaching for individual communities, access to tools and resources provided through a kind of a large knowledge management system, and then a evaluation approach for continual improvement. So these were kind of the intervention components. And our job as the evaluation leads was to develop both a formative evaluation component and a summative evaluation component. And I'll talk about each of those, and we'll talk about what we learned from each of these different evaluations. So when we began, we worked with the both the implementation team at IHI and the other implementing partners and the foundation to come up with a common set of evaluation questions that we were all interested in. And as you can see, the questions are the initial set of questions focused both on process and on outcomes. So the first couple of questions are really process questions. Are they learning and using the scale skills and tools? Are they increasing their readiness to improve? Are some of the kinds of things related to better behavior, better kind of understanding of how to change, how to transform systems within communities? Are they acquiring those kinds of skills? And then the last 2 questions were more related to kind of outcomes. So as we are beginning to build these skills, what is happening in these communities? Can we correlate what's happening in terms of the capacity that is being built to the outcomes that they're interested in? And are, finally at the end, are they actually improving their health and well-being? And, as I talk through the rest of this presentation, I'll kind of show how we kind of approach each of these different questions and kind of the extent to which we were successful in answering these questions and how our own evaluation journey changed as we were kind of following the path of these communities. So to put together, to address these questions, we put together what we considered at that point to be a kind of a innovative evaluation approach, as a multi-stakeholder, multi-method evaluation approach, where we had essentially 3 different prongs. So our evaluation partnership involved members from the scale communities, from the support system, that was the coaching system, the training system, the implementation team, and the foundation itself and the donor. And we had 3 different kind of modes of collecting data for evaluation. Traditional inquiry. So these were, surveys and focus groups and the kinds of things that evaluators do, to collect both quantitative and qualitative data about the progress of the program. Then because the program itself was so large and so diverse and so complex, we couldn't, and because all the communities were very busy, not just with, so the other factor here was that scale was only one, perhaps, of multiple programs that these community coalitions were implementing. So it was not as though that they were dedicated to just doing this work. This might have been 10, 15, 20% of their work. So part of our role was also to try to think about how did the work that they are doing here in scale fit with some of the other work that they're doing in their other projects as well. And so we had, to supplement our inquiry, to supplement our kind of traditional methods of data collection through inquiry, we also had data that we collected through observation. So the project records that were completed at specific points in time by the teams, sitting in on some of the mentoring calls, sitting in on some of the community conversations, and basically taking notes without asking questions, allowing us to get a little bit more understanding about the context within which scale was being implemented. And then finally having these reflection sessions. These we used a methodology called the critical change method, which is a method that was developed by MIT to look reflectively at things that had happened in the past and identify basically kind of high and low points, and using this map of high and low points to understand the process of change. So we used these three methods over a period of a year, year and a half. We collected large amounts of data. And we developed this kind of formative evaluation approach that was really, really successful. And in this paper that we've written about the approach, we used the approach to do a variety of different things. We used the approach to change the theory itself. So there were parts of the theory that were refined as a result of what we were collecting. We changed the implementation over time. We changed the support system. We provided guidance to the coaches about how to improve their coaching. And then as a result of the data that we were collecting, we continue to evolve our own evaluation process. So this formative evaluation piece, which was very much kind of embedded around kind of how do we learn as we go, how do we kind of build the boat as we are sailing, so to speak. This was a very successful part of our evaluation. And of course, a lot of it was because we had an evaluation team, because there was funding from the foundation for us to do the evaluation. It allowed us to be able to collect the necessary data that we wanted. It allowed us to be able to feed the data back. And so this was kind of a, we felt very good about this work that we did. And actually we won an American Evaluation Association Award for this work. So this particular part of the work, which is having an evaluation team collect data, learn from it, feed it back to the implementation, and kind of help understand the process of implementation, which were the first two bullet items of evaluation questions, that worked very well. But then at the same time, we were also called upon as part of our work to do the summative evaluation work, which is to be able to say, and therefore what happens as a result of all of the enormous amount of effort that has been built in capacity that has been expanded in building capacity for these communities. And so but we couldn't, because the summative work in some respect could not actually happen until the implementation was robust, until the implementation was actually was moving ahead in a stable way. And so we needed to develop a set of data collection instruments that would allow us to be able to go back and answer some of the other questions, the more summative questions related to the correlation between process and outcomes that we had been called upon to answer. And so we built up a variety of measurement systems in partnership with the communities. All of this was co-designed in partnership with IHI that allowed us to be able to measure. So in addition to the formative work that we're doing, that allowed us to be able to measure the results of what was happening within these community processes. And so these are some examples of what we built. We built some instruments to measure capability for change and how the capability for change was evolving over time. And we built some measures to develop for measuring in using traditional QI methodologies. So think about measuring run charts of progress over time for process and outcome measures. And then at the back end, because the whole objective of this was to be able to develop, to understand whether community well-being was progressing, we built in partnership with some colleagues at Kaiser Permanente and at Cincinnati Children's. We built some instruments that allowed us to be able to measure well-being, and these are both leading indicators of well-being, which are kind of social indicators, as well as adult and youth well-being measures. And so as you can see here, I'm not going to go into great detail, but some of these have been described in some of the papers that we've written. We developed a variety of these measurement instruments. When it finally came to using the data from these measurement instruments for trying to answer some of the summative questions, this is where we began to discover that we actually, despite all of our effort at putting together this schema for measurement, we ultimately were not able. The data that we had did not enable us to answer the questions we had set out to answer. And that was because, of course, a lot of this data was collected in the field. So it was not as though for the formative work, we had a lot of the opportunity to collect the data ourselves as an evaluation team. For the summative work, this was data that was collected as part of kind of routine program, kind of routine project work in the different communities. And so we did not have the same level of oversight over the data collection. And naturally enough, I mean, the idea was that this is, as we were beginning to think about developing learning systems, the idea was not to have a research overlay on the project implementation, but really to be thinking about how do we collect, how do the communities collect data that they can use on their own, and then how can we use that data for us to be able to evaluate what's going on. And as we saw when we began to analyze the data that was being collected, I mean, there were over 100 run charts across all the communities, but very few of them had more than a couple of points. Some of these were structural because the kinds of things that the community was looking at, if they were looking at nutrition, for example, and they were looking at attendance at perhaps farmers market, and this was in Michigan or in Minnesota, your farmers markets are 3 months a year. So we had data that was collected, perhaps we had data that was collected once a month over a 3-month period. And that was all that they could collect because that was the only times when the farmers markets were actually were actually there. And so some of these were structural issues, but some of these were also, it was just the burden of data collection, the burden of keeping the run charts operational. We found that there were a lot of gaps in data. We couldn't really link process measures to improvement aims or drivers. We couldn't link output measures to process measures. So this whole idea of being able to use data to be able to say the capacity that we built, what is the linkage between the capacity building and the outcomes, was something that we discovered we were not able to do. And this is kind of, as we look at some of the complexity literature, this is something that we read a lot. In the complexity literature, this is called FUPS, flawed, uncertain, proximate, and sparse data. So, and that is the reality. The reality is that there's a lot of things going on. There are a lot of different actors. There's a lot of heterogeneity. And so the data that you necessarily get is incomplete. It is proximate in the sense it's kind of very much process data around things that are happening, and they are not necessarily kind of the distance between these activities and outcomes is not always clear, nor is the pathway clear. And the data is sparse because, as I said, for example, if you're collecting farmers market data, you're only collecting data 3 months a year. So that actually caused us to pause. So this was where we were at in a little bit of a dilemma, because we had set out to do what we thought was a brilliant summative evaluation that where we'd be able to come up with these wonderful insights about how all of the work that had happened would lead to outcomes. And it turned out that the data didn't support that. And it was not as though we were able to say this is somebody's fault, because this is kind of the nature of the way that the work was done. This is the nature of the way everybody was working very hard. Everybody was doing what they can. And the reality was that on the ground, this is the kind of data that was available to us. So what it actually allowed us, what we did, therefore, halfway through the project was we redesigned our evaluation. And we completely turned the evaluation in partnership with both the communities and in partnership with the Robert Wood Johnson Foundation, which was very much open to our rethinking our approach, rethinking what is it that we wanted to learn. We redesigned the evaluation questions so that we were able to do something different with the data that we already had. And so the focus of the evaluation then was, rather than kind of thinking about correlation between process and outcomes, was really to begin going back to what I said earlier about Dr. Greenhalgh's thinking about how do we do complexity-informed research. A lot of what we want, we changed our evaluation to say, how do we address these inconsistencies, gaps, and infrequent data? How do we begin to understand context of each of these communities in a lot more detail, so that we're not just thinking about, okay, let's do some correlation analysis and try and figure out kind of what we're getting. The other key change that we did was, and I'll talk about this a little bit later, is that what we really wanted to capture was the story of these communities. That over the period of 2.5 years, these communities had accomplished a tremendous lot, but we did not have the longitudinal data. All that we had was these kind of monthly snapshots that were collected. And the question is, what happened in between? What is the story of how growth and transformation took place or did not take place within the communities? And then, of course, the final piece was, none of this we could do on our own as an external evaluation team. Even though we had thought of ourselves as a collaborative evaluation team, we were collaborative in the sense that we were collaborative in helping with data collection, but we were not collaborative in meaning making. And so this was a kind of a revelation for us as well, is that we as an evaluation team could not necessarily make any sense of this data without kind of active engagement of the communities themselves. And so we went back into the evaluation literature to try and think about, okay, how do we change what we're doing so that we can be more effective at generating meaning and insights from this data that we had, other than kind of, beating ourselves on the head and saying, well, we can't actually come up with the kinds of things that we wanted to do. And so we used some of the literature on from design thinking, some of the recent work that's done on how do we look at complex program evaluation data. And we began, so rather than kind of focus, what we began to do is began to look at an explicit way of being able to look at representation of the community's process of change and fill in the gaps, as I said, in the community story that we could not actually find from the data that was collected. And so we worked with these communities, each of these communities, to build these community journey maps. These are tools from design thinking that allowed us to be able to work with the communities to say, what happened in the span of the 2.5 years that you worked on? So this is one of the communities Remain. And what we asked the communities to do is to look at using these red circles to be able to say, kind of, what are the milestones? What are the things that we should be paying attention to? And then what are the positive things and what are the negative things? What really contributed to growth, and what were barriers and limitations to growth? And how do we begin to use these community journey maps to understand kind of stories of different communities so that we can begin to piece together common patterns? And so we launched on this process of joint meaning making. And we've got a couple of papers that are on these slides that we published around this. But what we did is we drew on traditional qualitative research methods. So participatory action synthesis and meta-ethnography are qualitative research. They're bottom-up meaning-making methods that have been traditionally used by qualitative researchers. And we repurposed them for kind of meaning-making with these communities. And so we led this in partnership with the communities. Our evaluation team led this kind of process of engagement and synthesis where we worked with multiple thematic subgroups. So we've got these 4 subgroups here: one around building community capacity and relationships, one of using QI skills and methods, one related to spreading and scaling up practices, and one engaging people with lived experience. And each of these themes, we asked the community to say, tell us what happened along your journey, along each of these themes. And how do we then bring all of these things together to look at what was common in the transformation journey and what was separate? And could we come up with different pathways of change in partnership with these communities? And so this was the approach that we used, and it's reported in detail in the paper that's on the previous slide. And so we had an engagement step where a lot of the different members of the communities came together to help us fill the gaps in the data that we were finding, but they helped us to tell us what happened in between these data points that existed. And then we had a smaller group that synthesized this data across communities to come up with essentially what we call mechanisms of change or mechanisms of transformation. And so these were the different areas in which we brainstormed with the communities. And ultimately, so rather than coming up with these correlational results where we were able to say X is correlated to Y, what the output of all of this work was to define pathways to transformation. What are the kinds of things that these different communities have done that have allowed them to transform? And we came up with the output of our evaluation work was ultimately these graphical representations of change. And so this was our pathway. We discovered that there were 3 basic pathways to transformation that the 20 communities that we worked with followed. One of these was what we call build core capacity. Ultimately, these communities did more or less the same things. They built a team and built capacity. They embedded people with lived experience in their work. They created relationships so that they could have a shared language for talking across multiple stakeholder groups. They focused on a kind of racism and inequity within community. But the ways in which they did this and the sequence and the order in which they did this depended on context, depended upon particular environment, And so we came up with these 3 different pathways. The first pathway is building core capability, where there was a subset of communities that focused on capability first. I need to know how to change. I need to get my improvement science skills. I need to get my implementation science skills so that I have the tools to change. The second pathway that communities followed is what we call create a shared language, where the tools came later. The tools were not quite so important, but what was important was that different stakeholders learned to speak to each other in a way that they could understand each other, so that if I came from the school district, or I came from the health system, or I came from the police department, or I came from a community activist organization, I was not coming in with my jargon, with my terminology, my vocabulary. I was having a common vocabulary so that we could really kind of get together to talk about what needed to change. And then the third piece was involving community early. Of course, because these were community coalitions, there was still kind of a gap between the members of these coalitions and the community members themselves. And so there were a set of communities that said, we can't really do this without bringing people with lived experience into our process right from the start. And that's the first thing we need to do. We need to be able to engage the right people so that we know we get the wisdom of the communities integrated into the work that we do. So these were some of the pathways to transformation that we identified through our evaluation process. We then, the next piece was then to begin to, we did kind of community systems dynamic approach to come up with these causal loop diagrams, where we went from this somewhat linear process of pathways we had in the previous slide, to really understanding, so how do these loops work? What are the dynamics of these systems? And some of the things that came up in these conversations was still, despite everything else, despite all of the support, despite all of the capacity building, a lot of this community transformation work was still dependent on available funding. As we see here, these red, the red arrows here, and I'm not going to go into a whole lot of detail here. This is described in our paper as well, but the red arrows describe the constraints and the blue arrows describe the facilitators, and the notion that ultimately, despite everything else, despite all of the capacity building, the fact that they were reliant on external funding was a major impediment in the ability of these communities to progress. So what were the conclusions from the evaluation? What we knew is that communities felt motivated and energized around creating change. They built strong personal and professional relationships across the coalitions. There was a strong emphasis on addressing racism and inequity. They all made a concerted effort to involve people with lived experience in their work. And they all launched a number of initiatives. A lot of things there's a lot of different types of activities focusing on transformation that took place. The things that we really couldn't know from the evaluation was what kind of traditional evaluation that we want to come and publish in research journals wants us to do, which is the extent to which health and well-being improved, the extent to which the changes attributed, what could be attributed to the scale activities, the linkage between change theory, planned activities, output realized, and outcomes. And so here is kind of where I think the kind of our challenge lies. And I'm kind of going to end my presentation. We're talking a little bit about, and therefore, where do we go from here? So I think what we knew, what we learned was truly profound, was truly valuable. The fact that it was done in partnership with the communities was a wonderful experience for everybody. But if we think about it from those of us wearing our traditional research lens, and so did our outcomes improve? Were you able to attribute outcomes to the activities? These kind of traditional research questions that researchers are interested in, we were not able to answer from this work that we did. Here's an example of one of the communities, the kinds of things that they did. And there are 7 or 8 different activities. And some of these are really, really complex activities. So for example, establishing food banks, or their goal was to address food security among low-income population. So they've done all of these different things. And each one of these is a significant amount of work. Each one of these is a significant accomplishment. But to be able to say all of these together contributed to improvement in well-being as measured by a well-being index, and each of these things happened only because they were part of the scale program, that neatly packaged kind of correlational pathway, which we all look for, is something that we were not able to establish. And so that kind of gets us into the kind of heart of what we are continuing to work with, or what I'm continuing to work with. And this is what I said, I don't really have answers, but these are some of the places where as we begin to think about developing learning community systems, so as we begin to think about participatory learning, as we're going to continue to think about co-design and co-production, the question is, how do we kind of balance the positivist perspectives that we are looking for from our kind of research hats? So we need objective conclusions, we need accurate data, we need generalizable results, we need to be able to attribute, compared to what we have on the constructivist side. We really want to be thinking about getting everybody to be motivated for action. We want to make sure that everyone is involved. We need to get sustained relationships. We need to have deep contextual knowledge. How do we balance these two things? And we have, as part of our work, we've been doing some scoping reviews of to what extent is this kind of challenge, to what extent does this kind of challenge exist in other community capacity building work elsewhere. And our scoping review found that pretty much, there's not a whole lot of work on thinking about how to do learning for quality improvement at the community level. A lot of the work still is very much project-based. They're focused on symptoms. So this idea of kind of fixing problems in one problem at a time, limited emphasis on understanding context of people. And so out there in the literature, there's not a whole lot of work that we can go to and say, these are the kinds of things that others have done that we can learn from. And so that gets me to the end of my presentation. The question is, where do we go next? And Dr. Sukas, Haritmos Sukas, is a philosopher who's written about the need. It's very much aligned in the management organizational behavior context. Has written about some of the kinds of things that I talked about earlier today. So he talks about the need for that. He talks about the fact that traditional research really requires kind of reductionist, simplistic approaches. Theories require natural simplification. And he talks about it's doing this kind of simplification ultimately doesn't do anybody any good. He talks about the need for complexification. And the reason that he says that we need to do complexification is because when we think about doing summative evaluation, when we think about doing the kinds of things that we set out to do, you have to look backwards. So we said, okay, well, let's collect some data and let's try to understand kind of what happens backwards. And so the traditional summative evaluation takes a backward look, while practitioners are experiencing what's happening while they are living it forward. And then there's kind of mismatch between this backward look and the forward progression of the way that kind of, of the way that change happens in systems. This is why the formative evaluation worked really well for us, because in the formative evaluation, we were marching forward with the implementers. We were marching forward with the support system. And so we were in step with what was happening. But the moment we switched to more traditional summative evaluation, we were looking backwards in a process that had moved forwards until we came back, until we filled the gaps by asking the communities to draw the journey maps, till we asked them to come back and tell us what happened in between. We were not in the kind of same space as they were. And so that's kind of what I want to end with. I want to end with, as we continue to grapple with learning in complex systems, as we continue to learn grappling with in communities, the question is, how do we complexify in a way that allows inclusive, equitable learning systems that involve both the transparent use of quantitative data so that we can answer some of the research questions that we're interested in, but also do it in a way that we do it in collaborative ways to bring about change. And I don't actually have an answer to this question, but this is kind of what I'm continuing to work with in my work at Cincinnati Children's. Thank you for listening to me. And I think I was hoping to finish at 12:45, but it's 12:50, and we have some time for questions. Thank you very much.
Thank you, Dr. Ramaswamy. We do have about 5 minutes or so remaining for the Q&A. So at this time, if there are any attendees who'd like to ask a question verbally, please do so by raising your hand, or feel free to enter into the Zoom Q&A. And I see that we have a hand raised. So Mary, please go ahead.
Thank you so much. This was a wonderful presentation. I am excited with it. A question that I have is that to me, it's almost like what you were describing was a developmental model, right? And
That's correct.
so I'm thinking about the length of time that we would need to take for the outcomes to truly show. It almost reminds me of the classic issue of quarterly profits versus long-term growth with the business, right?
Yep.
What are your thoughts about how would we switch ourselves to, away from that quarterly profit and showing outcomes in short term?
Yeah, that's a really good question. And in the paper, in one of our papers where you have the causal loop diagram, what we actually did was explore exactly that question with the communities. It's the fact that the kind of the structural issue was that because not only is it about short-term profits, but you're relying on kind of external grants for doing this kind of work. The grants themselves served as a natural limiter to understanding how transformation took place, which is a longer term process. And so, and also because some of these community coalitions this was one of many grants, they were doing grant chasing at the same time as they were doing this work for us. And so one of the things that we brainstormed was what would actually happen if you have a different kind of a different dynamics of your system where you really are focusing on capability building with the goal that you are going to be part of what you're going to do is you're going to build the capability for people to be able to collect your own data around transformation. How are you, so that you're not relying on transformation for somebody else to come in and do an evaluation and measure whether you have changed or not, but you have the infrastructure and the systems and the kind of funding mechanisms to be able to do your own evaluation over time. And that's the only way. And we come back to the idea of learning systems, and the definition of learning systems is they have the culture and incentives to learn over time. That seems like it's the only way to make this happen. And we're not quite there yet. So I think by being able to build the capacity for the community organizations to think about how am I going to continue to track my process of change, and how am I going to be able to kind of to measure and report outcomes. That is the only way that this is going to work, and we're not there yet.
Okay, and one more question, if there's one out there, Dr. Beebe.
Hi, thanks. What a great presentation. And I think it's exactly this sort of kind of thinking differently that we need to do in a learning health systems sort of paradigm. I was kind of struck that, I think you mentioned that you worked with 30 different communities representing different sectors and industries, and that's not easy to do, to engage stakeholders and communities of different stripes like that. And then you talked about like developing a common language and developing a coalition. How that's not that, that's a learned skill to try to be able to do that. Is that part of your CHILAs, the leadership and training?
Yeah, the CHILAs. So the IHI did a fantastic job at. There were two factors. One was the kind of the continued engagement of the foundation, of the donor, who was as committed as the implementation team to make sure that there was enough resources for capacity building. And the second piece was, IHIs they stepped out of their traditional role as being essentially a QI, as being a source of QI expertise, to build this large coalition of people with diverse skills to come and provide training and support. And the CHILAs were instrumental in being able to, and then with this explicit focus on relationship building, was something that they had. They had a leadership group that from Boston that was served as the experts for continued relationship building. So they explicitly did a lot of things around how do we make sure that these 20 communities stay together and move together during the duration of the project. And that's a question. So nobody is, coming back from wearing a research hat. We've not done a cost effectiveness analysis on this work. And, the amount of effort that was involved around with large numbers of people to build the necessary infrastructure was enormous. And without kind of a generous donor like Robert Johnson Foundation, The question is, how are you able to kind of propagate that across at this kind of scale?
Thank you.
Okay, and that's all the time we have. So thank you again, Dr. Ramaswamy, for taking the time to present at our CLHSS Impact Seminar. And thank you to all of our attendees for attending. In closing, please join us for our next seminar, which takes place on Tuesday, February 7th, noon Central Time, where we will be joined by Dr. Rachel Richardson. This concludes our presentation. We'll see you next time.
Thank you very
Thank you
much.
so much. Great job.
Bye.